Welcome to today's video. Now today I want to focus mostly on goings on in Africa because I managed to get some specific data from Kenya and it's all a bit strange. I can't quite work out what's going on. I don't think anyone can. Epidemiologists are arguing about this now, but the news appears to be good. So that's what most of this video is about, and if we get time we'll do some science stuff at the end. But I want to start off, I've got some more pictures from Evelyn on the California coast, and it really is quite upsetting what's happening out there. I really do so much feel for the people there. I mean, this shot here was taken at about 10:30 in the morning on the California coast. So this is actually in daylight. It looks like dusk, but it's in daylight. And again, you know, the visibility here is what, a few hundred feet. You know, it's incredible. 10:30 in the morning. Again, this looks like a night shot, but it's not. I don't know what the light settings were on the camera, but. And again, we see the smoke and fog in the air. Very grateful to Evelyn for sending these pictures in. There's a tremendous amount of fires and smoke. The health implications of this are really quite significant. I mean, this is going to cause a lot of respiratory disease, and it's also going to impact on other aspects of health like cardiovascular disease, cerebrovascular disease that people often don't think of straight away when they think about smoke pollution. Now these are from, this is Danette has sent these in. Thank you, Danette, for sending these in from Humboldt, again, California coast. And again, these are in the afternoon. These are daytime pictures. Quite incredible, the amount of smoke in the atmosphere. Now, this is a serious hazard to health. There's no question about that, unfortunately. Now, just while I'm showing you some pictures, before we go on to Africa, I think I'll just show you some pictures from David from Ag Unity. Ag Unity, of course, is the people that kindly supplied my poster here, and they supply posters in different parts of the world. Now, he's just sent me, he's got hundreds of these pictures, but we've just selected a few. These are the Ag Unity public information campaigns in Ethiopia. We were just talking about Ethiopia yesterday, actually. So this is the way that the R number can result in. I mean, it's just so graphic, isn't it? You know, it's just so, you know, infographics is just so clear. So with a low R value below 1, we get low numbers infected. If the R number raises, get more than if the R number's 2. Here we can get all these people after a relatively short period of time. It really is graphically illustrated. Here we have hand washing and mask wearing, and here we have another one. Community health, and doesn't that picture just speak 1,000 words? You've got these 4 blokes here, look, all wearing masks. They're wearing gloves. Well, we could argue about wearing gloves. All socially distancing, all reading, taking in the information they need to help their communities. It's just the way it should be. Healthcare should be of the people, for the people, by the people. Again, another group, all mask wearing here. More public information. You know, it's just, oh, there's the same one off my poster. Look, again in Ethiopia. So I think it's just a tremendous service. And the actual material that these are made of, it's actually very tough, sort of, you know, sort of canvassy material. I think it's just a tremendous project, just simple messages that save lives. Anyway, moving on to the thrust of today's talk about Africa. Now, I'm going to use Kenya as an example because I've got some specific data from Kenya. Now, this is the official figures in Kenya. 36,205 cases, 624 deaths. That gives us a case fatality rate of 1.7%. And of course, this is absolute fiction. and can be completely ignored. That's the Johns Hopkins data. Now, what happened in Kenya was there was a fairly early lockdown, which is good, back in March. Domestic travel was greatly restricted. They did good work on contact tracing teams, isolation facilities across the country. So the contact tracing team seemed to work fairly well, as far as we can gather. And they did establish isolation facilities. Now, they turned out to be very much a two-edged sword, as we'll see. They probably did a lot more harm than good, actually. But we'll see that in a minute. But the contact tracing team's good. And Kenya, unfortunately, has got quite a lot of experience from HIV, same as South Africa. So there was people that were already really quite skilled in this contact tracing thing from the HIV. That's still in Kenya, of course. It's still highly endemic, unfortunately, although largely controlled with highly active antiretroviral drugs at the moment. Doesn't take it away, just controls it. So masks were mandated outside, which is good. Hand washing and temperature checking points sprung up across urban areas, so places to wash your hands when you're out shopping, people randomly checking your temperature when you're out shopping, all good. Then if someone had a fever, they could be sent home to isolate. Now, of course, you can fiddle this if you take paracetamol, that's acetaminophen or Tylenol, or if you take ibuprofen, that will artificially lower the temperature. So these aren't foolproof tests. And of course, we know that not everyone gets a fever. Many people don't get a fever, surprisingly enough, for a viral infection. But you know, it's all reasonably good stuff. But, and there's a huge few buts coming up now about Kenya. Antigen tests were almost all private, and they cost between $10 and $100 a day. Now, I've done a little bit of teaching in Kenya, and $10 in Kenya is a lot of money. It's a lot of money to most people. It's several days' wages to most people, and $100 is just forget it. You know, $100 would be a week's wages for. It just doesn't happen. So, and the government wasn't supplying any antigen testing. It was all, or virtually all, like 99% as far as I can gather from the data that we have, private. So Dr. Richard Ayah, Public Health University of Nairobi, senior lecturer, guy knows what he's talking about on the ground. The testing figures reflect the ability to pay, not the reality. This is a great pity. And this information now, of course, has been lost. We'll never know. And the reason that is such a pity is it's bad for the individuals, it's bad for the people of Kenya. But there's something immunologically going on here that no one understands because of the very low death rate that we're going to celebrate, really, in a minute. You know, the world is really missing a trick to learn a lot about how this virus is interacting with the people in Africa. So it's bad for the people, it's bad for the country, and it's bad for the human knowledge. It's all a pity that data was missed, but it was. No one went to collect it. Now, this is surprising. There's a big social stigma to the disease in many parts of Africa. Now, we don't really relate to this. You know, if I can't go into work because I'm sick, or ring in and say I've got a fever, I can't come in today. It just happens, it's fact of life. You know, I'm not ashamed of it. You know, if I ring in and say I've got a terrible hangover, I can't come into work today, then that's different. That's my fault. But that could be a shameful matter. But if you get a fever, how can that be shameful? I suppose the only way I can look at it is psychiatric conditions. I'm tempted to give you some examples. I'll maybe give you one example. Years ago, I had I've told you before, I had anxiety difficulties, and I've got a particular friend I can relate this to, and I told him about this. And he never mentioned it in public, of course. But then one day I got a knee infection, a staphylococcal skin infection. Knee hurt like heck, basically, for a while. It went all inflamed, and Because when people are sick, they'll announce it in church, and he said, "Oh, John Campbell can't do his thing today. He's got a sore knee." So like having a sore knee is completely acceptable, but having anxiety is not. I guess it's a bit like that. When in fact they're both biochemical disorders, really. I mean, one's a biochemical disorder, one's an infectious disorder. I mean, anyway, I digress. Apologies. Now, people in Kenya were frightened. Anyway, so there's this public stigma. That's what I'm trying to make out, and we don't relate to it, but it's that culture, so you can't argue with it. Fear of government quarantine facilities is another problem. Now, between April and May, probably thousands of people with suspected infection were rounded up and forced into government isolation centres. And they were forced to pay fees, and the fees were very high for the local people. So they were rounded up and forced to pay what for them was really exorbitant fees. Yeah, there. So Mrs. Jones, for example, obviously not a real name, we're protecting people here, was forced to be tested, isolated for 4 weeks, and forced to pay $20 a day. Now that $20 a day to you and me might be affordable. Okay, you might have to live on beans and toast for a few days, but $20 a day for 4 weeks, a lot of us could stretch to that. But for her, it was a life saving. She was devastated. Her daughter's education could no longer proceed because she was forced into this isolation centre. So quite an appalling situation. So not surprisingly, people who are infected try and hide the fact. They don't talk about it. Sarah, a nurse, obviously not a real name, working in Kibera. Now, Kibera is a huge shantytown area. It's part of Nairobi, really. I wanted to go there, but you can't. It's very difficult for foreigners to go there for various reasons, so it was hard to visit. But anyway, so Sarah, anyway, working in Kibera. This hardline approach has dealt fundamental damage to the overall public health response. People are simply not admitting they have the infection. Removed any incentive for people to get tested for COVID-19 symptoms, if they could afford it anyway, unless they are on death's door. So the government approach here with enforced quarantine has seriously backfired. And this means there's a lot more cases around than are officially known about. Now, Dr. Ayah again, from Nairobi University, estimates that despite this, so we said the official number of deaths is 624, but he estimates there are only about 4,000. So there is an incredibly low death rate, phenomenally low death rate, especially as we'll see, it looks like millions of people have been exposed already. I mean, the official figure of people infected was 36,000. That's just a joke. So I don't know why Johns Hopkins bothered publishing it. But it's not a joke. This is serious stuff. These are the numbers of life, aren't they? Kenya's Ministry of Health, 80 to 91% of infections in hospitals seem to be asymptomatic. Very high rate of asymptomatic infections. Now, not many studies done, but I did find this one in a science journal. Look it up yourself. I've got the details there. A good report. And it published on the 2nd of July. So it's a long time ago, and this is the most recent data I can find for Kenya. Way out of date, I know, but it tells us a lot of what we need to know. 2nd of July, 2.7 million people in Kenya have been exposed. 2.7 million. Little more than the 36,000 diagnosed by Antigen testing, of course. And this is Kenya Medical Research Institute and the Wellcome Trust. Wellcome Trust, of course, superb medical research organisation. Do visit their museum if you're ever in London. 12.4% of Nairobi residents could have the virus, they estimate. Kisumu, the third largest town, 7.5% of the samples tested. Mombasa, down on the coast, it was 8.6%, and this was based on 2,500 blood results between April and June. So okay. It's not huge numbers for the country, but it is. And the Kenya Medical Research Institute and the Wellcome Trust know how to take these properly. And it gives us the best figures we've got from 2,500 samples. So this data is not a long way out. And we're looking at these large percentages of the population being infected already. And of course, this is the 2nd of July. Where it is now, who knows? Who knows? You'd expect probably most of the countries to have been infected by now. It's estimated that 78% of patients are asymptomatic who have mild symptoms. Now, this number, of course, this 78%, is different from the official government of 80 to 91%. But this figure is generated by the Kenya Medical Research Institute and the Wellcome Trust, therefore is more likely to be the accurate figure. But it's still incredibly high. About 80% of people have asymptomatic disease. This is incredibly good news. And remarkably low death rate. Remarkably low death rate. Did I talk about the death rates? I think I did I? Yeah, I talked about the death rates. The death rate in Kenya as a whole seems to be about 4,000 for several million infections. I mean, this is remarkably good news, or appears to be remarkably good news. Now, this other article I found here about Kenya also looked pretty reputable. Africa dampening the storm. Now, what this article did was it talked through the reasons why the death rate in Africa was probably so low. And one of the things was, and this was startling, the mean age in Africa is under 20 years old. It's about 19.7 or 19.8 years of age, because so many of the older people have died already. So it's a very young demographic, so obviously that's going to increase asymptomatics. But even that doesn't fully account for it. So what this article thought was that people in Africa are exposed to so many different infectious diseases. Parasites, bacteria, viruses. We have plenty in the West, but in Africa there's even more of these conditions. I mean, I did a short course in tropical diseases at Liverpool, and you spend the Liverpool School of Tropical Medicine, and you spend the whole time learning about infectious diseases. Now, having said that, there are non-infectious diseases as well in older people in Africa, but infectious diseases are so prevalent. Now, and what I think, this is kind of a theory, it's not based on very much at all, but I think what may turn out is that circulating in Africa for some time, there has been other coronaviruses that haven't been identified in the 7 main types of coronavirus that have already been identified in the West. That's the 4 that cause the common cold type features, the SARS-1, the MERS, and now the SARS coronavirus 2. So I suspect there might be unidentified coronaviruses circulating in Africa. And they're not the same as this novel coronavirus, because we know this virus is new. But if they're similar, if they had a 50% similarity, then the immune system would already be partly primed to be able to generate immunity to SARS coronavirus 2 quickly. That's a phenomenon called cross-immunity. Now, I suspect that explains things quite well, but of course we don't know. We haven't got the data. No one's been there to collect it. So all very frustrating, but this article correctly says that Africa should be part of the roadmap for COVID-19 research. Absolutely. So much we can learn from that situation. Meantime, people in Africa are just grateful that they are having very low rates. Facilities that have been constructed to look after coronavirus patients aren't needed. But there's more deaths in Brazil, India, the United States, Europe, way more. Brazil, there's been a high death rate. India, still don't know, but there's certainly concerns about India at the moment. And recent data has recorded low infection rates over the last month in Kenya, which could be a bit of a mystery, but could be explained by the fact that so many people in Kenya have been infected. If it was 2.7 million back in early July, it could well be that Kenya has reached herd immunity. We don't know. We need a big antibody study and a T-cell study to try and find that out. So there we go. Africa generally, very low mortality rates. Not as low as they appear because of the rubbish testing, limited antibody surveys, virtually no T-cell surveys, rural areas where people die quietly. So the number of deaths and cases are way, way higher than are reported, but yet seem to be way, way lower, genuinely way, way lower than Brazil, India, the Americas and Europe. So I don't know about you, but I'm very curious. But for now, let's just celebrate that far fewer people are. I mean, back in March, the World Health Organization and me were looking at Africa and thinking 3-4 million deaths. It was not looking good, but thankfully, so far, it doesn't seem to be the case at all, even if we don't know why. So Sten and Rita I've been watching for a long time. I can't quite remember where, somewhere in the States. But always good to see long-term viewers, and the vitamin D, of course, is good. So thank you for watching for such a long period of time. I think I'll leave it there for now. I think that's long enough for now. I might come back and do some more science. We'll see how we get on. But thank you for watching. Thank you for watching that. And let's celebrate the situation in Africa, but let's try and find out why, even if it's only vested self-interest. We really need to know this one.